Good afternoon, everyone. I'm presenting my free paper on comparative analysis of new ILPA calculation methods after myopic LASIK. Uh, no financial disclosures. With the introduction of refractive procedures like LASIK and PRK, many patients underwent the procedure to be spectacle independent. Today, many of the post-LASIK surgery patients are reaching at an age at which they'll develop senile cataractus changes. ILPAR calculation in post-myopic LASIK patients using standard formulae like SRKT, Hoffer, Holiday frequently results in undercorrection and thus a hyperopic surprise in myopic surgery patients and a myopic surprise in hyperopic LASIK surgery patients. So why does this error occurs? Because after myopic LASIK, the anterior surface of the cornea basically becomes flat, and the conventional keratometer and the topographers provide incorrect corneal power values and tend to overestimate the corneal power. And also, there is error in the ELP determination, and hence the underestimation of ILPAR is there. There are several approaches have been given to correct these errors using the previous refractive surgery data, and current corneal measurements, and using no prior data. Since at the time of cataract surgery, no prior data is usually available, hence, in majority of the cases, the purpose of the present study was to compare the accuracy of ILPAR calculation methods in post-myopic LASIK surgery patients using AS-CRS ILPAR calculator. It was a retrospective comparative case series done in 20 eyes of previously undergone myopic LASIK. It was done using cataract surgery. Inclusion criteria was cataract surgery done using temporal clear corneal incision with phaco with accuracy of IL implantation. All eyes with corneal opacity and intraop complications both of LASIK or cataract surgery were excluded. Basically, parameters of IL-PAR, post-LASIK, K1, K2 using topography, true net PAR use at 4 mm using pentacam, axial length, ACD lens thickness, white to white using IL master had been input into the ASCRS IL-PAR calculator, and the IL-PAR calculated through the methods using Sharma's, Hage's, Potwin, Pentacam, and Barrett's Trukino history had been computed, and the average of the all four methods had been computed, and the average ILPA ILPA was imputed by the surgeon. Stable manifest refraction at the spectacle plane after refractive surgery was obtained at 1 month postoperatively. And calculation of refractive prediction error was taken into consideration with 0.7 diopter of refractive error at spectacle plane, causing 1 diopter of IL prediction error. Main outcome measures at one for each method were mean, median numerical error, mean absolute error, percentage of eyes within 0.5 and 1 diopter from the target refraction. Statistical analysis was done using Kruskal-Wallis test. Coming to the result, mean age of the patient was 47 years, and axial length ranged from 24 mm to 32. And the least refractive prediction error was in Barrett's, although there was no statistical difference in mean, median, and mean absolute error in Sharma's, Hage's, and Potwin and Barrett's. Though a hyperopic refractive prediction error was reported by Potwin's Hill formula, other three formulas reported a myopic refractive error, though it was not significant. All the four methods gave good outcomes with maximum eyes within 0.5 and 1 diopter in Barrett's. The difference was not statistically significant. With very few studies published using no prior data formulas. So we compared with our study with two recent studies by Abulafi and Potwin et al. And it was seen that in results of formula by Hagees was similar to our study, while for Sharma's result of formula, it was slightly higher refractive prediction for our study as compared to the other two studies. Potwin-Hill formula gave a slightly hyperopic error, similar to the Potwin et al. Since the formulas are recent additions, there was no head-to-head comparison between a Potvin-Hill formula and Barrett-True-K formula, which is basically, Potvin-Hill formula is basically a formula in which basically cornea measurement of posterior comma for measurement is done directly, as compared to Barrett's-True-K, which is measuring using a regression formula, which is done in majority of the studies. And coming to refractive prediction error, the results was maximum were better in the Barrett's-True-K formula as compared to the Abulafia et al. And Potvin-Hill et al. Reported better outcomes in the Potvin-Hill et al. Formula. Limitation of the study was that it was a small size because these cataract surgery patients are gradually increasing, because 20 years back they had undergone LASIK. Now gradually they are entering the cataract age, and it was a retrospective design. Strength of the study is that it is comparing the newer ILPA calculation methods, and as discussed earlier, there is no study which is comparing the Barrett's-True formula with the Potvin-Hill, which is directly comparing the posterior corneal curvature method. To conclude, all 4 ASCRS methods are comparable. Potvin-Hill method gives a hyperopic shift in contrast with the other 3 methods which give a myopic shift. Thank you. Would like to acknowledge Dr. B.K. Jain sir, and Dr. Gautam sir, and Dr. Rajendran Khan sir. Thank you. Thank you APAO for giving me opportunity. Thanks a lot. Thank you, sir. Thank you, ma'am.
I don't have any questions. Any questions?
Thank you. Thank you.